So, thank you everyone for joining us for this follow-up to our previous session on patient narratives in undergraduate clinical education. Just a few housekeeping notes before we start. The session will last approximately 60 minutes, and if you would like, we want this to be as interactive as possible. So if you want to ask a question, then make sure to use the chat field. You can access the chat field by clicking on the chat button at the bottom of your screen. We may not have time to answer all of your questions, but we'll provide a document after the webinar with any questions that we don't get to. The chat field is also available to you to contribute to the conversation, and we may invite some participants to expand on their comments by asking their permission to make their audio and their video live. So if you are interested in becoming a temporary panelist, then please respond via the chat feed that you're happy for us to add you. The webinar is being recorded and a video will be made available on the ASME website along with any other supporting materials a few days after the webinar. And if you're having any technical problems, we'd ask that you make ASME aware by emailing events@asme.org.uk rather than adding it in the comments field. So, without further ado, would all of our panelists be able to introduce themselves, starting with Selina?
Hi, I'm Selina Robertson. I am a newly qualified doctor working in the northwest of England.
Jayne?
Hi, good morning. Thank you to everyone for joining us and ASME for hosting the event. My name is Dr Jayne Garner. I'm a senior lecturer in medical education at Wirral University, and previously I worked at Liverpool University. I was supervisor for Selina's project, so I'm just interested in the conversation, how we can develop the patient narrative and a wider perspective on this as well. Thank you.
Roshni?
Hi, I'm Roshni Beeharry, Dr Roshni Beeharry. I'm a medical educator, portfolio medical educator, sessional tutor at Brighton, GKT and QMQL. And previously, in my previous life, I was an NHS rehabilitation medicine consultant, so 18 years in the NHS. So clinical experience of patient narratives and patient work, but also a keen interest in the medical humanities, particularly creative writing and an interest in narrative-based medicine. So I'll be sort of incorporating some of that angle in our discussion. Thank you.
Fantastic. So this is a follow-up to our previous patient narratives webinar. So Selina, thank you for joining us again. Would you be able to give a brief summary or refresher of what your study was about?
Yeah, love to. So this was a project that I completed in my second and third year of medical school on patient narratives in undergraduate clinical education. And my starting point for this was an interest in patients' voice and autonomy, ideas around language and power, and how that would feed into medical education more broadly. I set three aims, which was to investigate how patient narratives were used in undergraduate medical education from the perspective of senior clinical educators. I collected original data via semi-structured qualitative interviews, and then analysed that, looking specifically at how the narratives were used within the context of teaching at hospitals in the northwest of England. So in terms of the data analysis, the transcripts from the interviews were coded and thematically analysed, and there were 5 participants who took part. And the results were sort of broken down into 3 main categories. The first being the teaching, the pedagogical applications of narratives. Secondly, the personal and professional development, and suggested modifications to medical school curricula that came out of these conversations. So in terms of the teaching applications, the participants all viewed patient narratives as really sort of very useful tools for encouraging empathy, reflection, teaching communication, and creating a safe space to explore emotive content. In terms of personal and professional development, again, these narratives were viewed as a trigger for empathy in the clinicians themselves, also a trigger for behaviour modification and use for catharsis and a space to explore, maybe process moral injury. In terms of the suggested modification to curricula that came out of these conversations, all the participants advocated that medical students should have more opportunities to debrief, and that maybe using narratives would be a tool to facilitate that, and that students shouldn't be shielded from patient complaints. They should be able to witness and understand what happens when things go a little bit wrong, and that was potentially a really powerful learning opportunity. The theme of empathy sort of spanned all of those categories, and I asked the somewhat problematic question, can empathy be taught? And all the participants rightly said, well, that's a bit of a trick question. It doesn't work that way. This is a quality that we're trying to develop. But they used narratives to do that, either from their own experience or their colleagues' experience. And they were seen as ways of awakening students to the complexities and the realities of patient-centered care and how important empathy was in that. Obviously, this was completed sometime before lockdown, but also in the last session, we sort of touched on, can we use narratives in interprofessional learning? Might there be some applications in teaching during lockdown, and should or could they be incorporated into curricula more formally? And I hope we can explore some of those issues today.
Fantastic. And Jane, what's your interest in Selina's research?
I was Selina's supervisor, and I supervised research and scholarship projects at Liverpool for second and third year students. It was quite rare that I would get a project that was around qualitative research, and I've done quite a bit of work in qualitative research. That was my PhD in medical education as well. So it was really interesting for me to have this perspective brought forward. And as an educationalist, it was really interesting reading about the interview transcripts as we analysed them and went through the data that we had, and how applicable this could be, how it could be used from different models of learning delivery, whether it is PBL, case-based learning, and how this can be integrated into sessions and used. And there was also aspects of it, and I know Selina has touched on some of these, around IPL particularly, and how we could use these kind of narratives effectively for different perspectives to develop, whether it is nursing students, radiographers, nutritionists, social workers, other health and social care professionals. And also developing, empathy, but accountability as well, near misses, what's been stressful for people and how they've dealt with that as well. And so I think there's a lot of implications that are quite subtle and nuanced, but can be really interesting to develop further. As Selina sort of touched on, and leading on to people like Roshni as well, their experience of storytelling and how it works with that. So this is just for me a really interesting opportunity to look at how we use narratives, whether it is patient or staff, and how we can develop them further as well.
Oh, fantastic. And Roshni, you're approaching this from a slightly different perspective, from a perspective of medical humanities.
Yes, no, thanks. But linking into, I'm glad that Jane brought up, staff narratives, because we all, as clinicians, as students, in all healthcare professions, we all have a story to tell and lots of experiences. So I'll touch on that as well, because that's actually some work I have done and will be doing with writing for wellbeing for healthcare staff. I'm interested in patient narratives. I'm interested in storytelling. My particular interest is creative writing in healthcare education and arts in health. So I can see patient narratives linking up rather beautifully with that. And I think there were really interesting questions from last time, lots and lots of interesting questions. So there were questions about, patients as educators, and also, which obviously, is the main point of patient narratives. But I sort of thought about this in a way of looking at patient narratives. We normally see them written. We also, there is, I just did some research on the internet, but when you Google patient narratives in medical education, you do have a lot of resources from the NHS. So I think that's a really good resource, and we'll put that in a document afterwards. But Prof. Claire Morris was here at the last discussion at Selina's original presentation and brought up some really useful resources like patient voices and patient stories. So looking at sort of digital storytelling, so first person accounts of a patient experience. And it's interesting, I think a lot of you still work in NHS. I can see some participants, those of you who work in NHS trusts or other places clinically. First person storytelling on video is often to do with, patient experience or of an actual service. So that's really, I think that's really useful for students and trainees to be aware of as a resource. And there's lots of good resources about how to engage patients in storytelling actually online. So I'd recommend looking at those. So NHS improvement sites are a really good resource, patient voices and patient stories. And then, every trust has its patient improvements. I think those are really good resources. Looking at the humanities side, film. So there are lots of, I was a rehabilitation physician, so sort of things that I would think about using in teaching, and it'd be great to hear what all your resources are. But films to do with disability, for example, the famous novel, The Diving Bell and the Butterfly, about a chap who had locked-in syndrome. I used to look after people with locked-in syndrome. Was also made into a film, and I thoroughly recommend it. So I think we can learn a lot from, adaptations of people's first person stories. Creative adaptations might not necessarily be, very accurate, but I think, there's a lot to offer there. And that's the sort of field of narrative-based medicine, in which I'm not an expert, but which links in nicely, I think. So films for public viewing, I think I'll call that. So they can be adapted from books or be created. So other ones related to disability is a French film called The Untouchables, about a chap with quadriplegia. So I think resources like that can give you an insight as a healthcare professional that you don't necessarily get when you're looking after someone. And I think the other things to consider are written narratives. So I've got sort of various things I've read here and resources that I'll put in. But books like Sinead Gleeson, who's an Irish writer, she wrote essays about life, motherhood, and she has a bony condition, an illness, and it's just come out recently. And that, although she didn't intend it for a medical audience, it's public. It's a set of essays. I think you can find lots of insights there, and I've used it when I've designed a poetry workshop with my colleague recently, Dr Neil Singh at Brighton, to look at dignity, patient dignity, and how she experienced, well, I've got a quote here, but if we have time we can read it later, but how it powerfully, someone's first-hand account, so it's not necessarily to healthcare givers, which would normally be what we're experiencing as clinicians, but there's a really powerful, there are lots of really powerful accounts of how she experiences illness, and other people who are experiencing. There's a whole field called autopathography and illness narratives, so of how people are perceiving illness, and that might not necessarily be written for a medical audience. Part of that is therapeutically writing for themselves. So yes, sorry, that's quite a wide-spanning answer. And that's not even all of the field. But thank you very much, because this is such a fascinating field. But I think there is a lot that we could take from, first-person accounts, written, digital, fiction, film, and other media to learn. Thank you.
Fantastic. So that's given us a huge, broad number of topics that we can explore. So I'll start off with exploring interprofessional learning. So there are a couple of comments last time about how nursing, allied health and social care have more actively engaged in working in partnership with patients. So how can we use patient narratives to enhance interprofessional learning, do you think?
I think, is it okay if I just, pick a little bit of this up? I think it's the structure in the current climate as well. And I know certainly during lockdown, I've been living with my brother who's a nursing student, and sort of, party to some of his teaching and discussions. And obviously from my role, it's been quite interesting just discussing between us how these sessions are delivered and how it would be workable, to manage it online learning as well in these kind of virtual environments. And I think there's a real opportunity right now to do that. So I think it's just how these are structured, how the students perhaps are introduced and build up a relationship as well, because obviously if it is very nuanced, empathic sort of stories, very emotional things. It's how that's handled and managed as well, because some students do really concentrate on things and think a lot about them. So it's making sure that they're supported to do that effectively as well. And this is something that Selina and I have sort of picked up as well and discussed about maybe writing something, whether it is with nursing students or how we could frame that discussion and pull it together. And I suppose that's why, because obviously my field is, I've always taught in medical education with medical students. I teach physician associates as well. But it's how to bring those, disciplines together really to make the sessions as effective as they can be for everybody and not dominated by one particular viewpoint, so it isn't necessarily that, and the medical students who lead the discussion, it is like a very fair sort of equitable learning environment as well. So I suppose that's something that I was interested in picking up. But I know we have a variety of people who've commented who have a wide range of experience and background. So I'm interested if people have any suggestions or things that they have found that have worked in that kind of context as well.
Cool. So one thing that you alluded to was this idea of having one narrative told by several perspectives. So is that something that would best facilitate or better facilitate IPL?
I think it would certainly foster insight and a wider viewpoint, which I think would be really interesting. And also I think often, case-based learning, problem-based learning, they can be quite narrow, the scenarios in that regard. So, medical students will have patient groups come in or, patient representatives come in and discuss things, but not necessarily other professionals, whether it is social workers or other people, to give that kind of perspective. So I suppose it is the scenarios that we have as well, developing them more effectively for IPL. And so that is something that I'd definitely be very interested in taking forward as an educator. But I don't know, I mean, Selina, having come from, recently, having done medicine and studied it, how would you see that working effectively for you as a student?
Yeah, I think pick up on a couple of interesting things that you said is obviously as soon as you qualify, you're expected to work in part of a team with various professions that you might have very limited understanding of what their remits actually are and how you fit into that. So I think narrative could maybe be like a unifying learning experience with these different professions to prepare yourself to enter the professional environment and work as part of a team. And also to pick up on what you said about this sort of like hegemonic discourse, which is the doctor and the patient, and not really having a voice for these other really crucial health professionals. I think that there must be some way, whether it is narrative from various perspectives, of exploring and sort of deconstructing that sort of emphasis that's placed on doctor-patient and breaking down those barriers to incorporate other healthcare professionals. I think that would be a really useful experience.
I'll just chip into that. I, as a medical educator, my first job at St George's was clinical skills. So clinical skills lecturer, and actually 6 weeks of that was interprofessional clinical skills. So working with physio students, medical students, and radiotherapy students and healthcare science students. So all working together, learning generic clinical skills. So I think, obviously that's not universal in across the board in medical schools. And as a rehabilitationist working, having led and worked with lots of interprofessional teams, I think that's something I'm very we need to in our training to practice as clinicians as well. So I think that's interesting that when I interpreted the question about multiple narratives, I actually thought about the other aspect was don't forget the families. So the people that are involved in patient care. So as patients at the heart of the team. So the patient's a member of the team, always, whatever specialty you're in, whatever field, A&E, you meet them for, a short time, or you look after them for 18 months like I did, or general practice lifelong, hopefully. But patients always, at the centre of a team, and their narrative, it's not linear. I think that was an interesting thing that I thought about, on narratives. We're talking about narratives and storytelling, which I don't know what your morning was like, but mine was like this. So, you know, remembering that as well, and bringing that into, you know, when we're designing educational intervention, but bringing in the family. So that was a lot of my work, and I know it's a lot of, you know, some of my specialist colleagues and general practitioner colleagues. So a lot of the work is dealing with family and social issues. And you mentioned social work, charities, third sector. So there are a lot of different people's voices that are represented, as well as the patients, and hopefully being, you know, the one that's promoted as the strongest. But remembering that there's a network of people that are involved in patient care, and also the setting. So I think someone last time was really, really good questions about secondary and primary care, and you know, I'm always going on about the spectrum and being a secondary care physician, but you know, in a dealing with people with long-term disability, that's a spectrum. So I think, you know, there's lots of potential there for looking across. You know, there shouldn't be boundaries, but looking across the sort of secondary primary divide that shouldn't exist when we're talking about creating, you know, educational opportunities, be it in general practice or secondary care or community practice medicine. Yeah, so I think that's a really rich area with interprofessional care, both at medical school, nursing school, and maybe integrating more there earlier, using your own narratives. So I mentioned Schwartz rounds. I don't know if anyone else has got, in the last talk when I mentioned in the chat, when I was part of the audience, Schwartz rounds. Now, I haven't got lots of experience, but I know that's something that's set up at NHS Trust, but I experienced it as a co-facilitator when I was in my last job as senior teaching fellow, and that was just for students. And I think that would be it was a really powerful way of getting nursing students, medical students. There was physio students, psychology student there, students from different professional backgrounds, you know, at an early stage of their clinical careers, training to share experiences together. So if we're looking at staff and student experiences, I think that's a powerful model that could be replicated in medical and university-based settings.
So, yeah, some of the Schwartz round sort of research I've seen, it's everyone from porters, healthcare assistants, you know, from all areas of the healthcare team as well. So again, developing that kind of insight, you know, from a much wider perspective, because some sort of members of staff will have spent more time with family, with carers, and been more involved with those discussions in perhaps a less formal way, but equally as valid from, you know, the patient perspective and of events as well. So I think that will be really interesting to pick up on.
Yeah, definitely, because the hospital Schwartz round that I went to was actually a dementia conference, again, in my last job, but it was set up by my colleagues that run Schwartz rounds in the hospital, because they're normally in the hospital setting, as you say, with, you know, all people from all disciplines and departments coming. But it also involved carers, because it was about dementia and people who were in the early stages of dementia. So there's a way of capturing, you know, in clinical training, there's a way of, I don't know if all Schwartz rounds involve carers and patients. I'm sorry, that was my only one. And I don't work in the NHS anymore, but I'd be really interested to know from anyone else any of our participants, whether, you know, they've got experience of that, and, you know, that's a way of bringing in patients and carers as well within an environment with learners and professionals. Thank you.
Oh, fantastic. And it's good that you brought up Schwartz rounds, because not only is it a fantastic tool for developing interprofessional learning, but it's also an excellent reflective tool, isn't it? So through exploring patient narratives, have we found a better way of reflecting? And someone in the audience has also asked, could someone explain what a Schwartz round is? So yeah, could you explain what a Schwartz round is, and then how can we better use narratives for reflection?
I was just going to say, I might defer this question if Rinny's happy, but I think Dr. Rinny Paul was saying she's clinical lead for Schwartz rounds. I don't know, Rinny, sorry not to put you on the spot, otherwise I can give what I know. But it'd be really nice to have someone who's actually experienced in that. But don't want to put you on the spot. But effectively, as I understand, oh great, she's happy to explain. It'd be nice to hear someone else's voice than mine. Is that all right, Ryan? Can you get Rennie on the line?
Hello, can you hear me?
Yes, yes.
Great. So Schwartz rounds have a very specific format. They're an hour in length. They usually have 3 or 4 panelists telling stories, often on a topic like dementia, as Roshni mentioned, or it could be a patient story told from 3 or 4 different perspectives. So the stories are sort of the springboard for a safe, reflective discussion that happens afterwards, that's facilitated by the clinical lead and the facilitator. It's a place to discuss the emotional impact of the day-to-day work we do. It's not about problem solving, or thinking what could have been done differently or better. And I'm just always amazed. We've been running them for a few years in Islington in North London for the community. Before COVID, people would travel, from their jobs, and we'd get 50 people sitting in a room together because they really valued this place and hearing other colleagues sort of who were going through similar experiences or difficulties, or just knowing that we're all in it together. It was a real sort of really brought people together. We did consider doing one with patient educators, and then COVID hit and we haven't got to that, but we're also doing we've got a pilot project with IPE students at King's, so that to do Schwartz rounds, because we hope that will be a really nice, safe place to bring everyone together, and for our students, dentistry, nursing, medicine, physio, dietetics. There's a whole long list. Apologies, I've forgotten some of the other groups, but it's really exciting to be able to get all these students together. And I think there are opportunities at the moment with the pandemic to get everyone online as well. I'll end there.
Oh, fantastic. So, really, what's your perspective on both using Schwartz rounds and patient narratives as a tool for reflection?
So I think it's really crucial. I wish all our students it was commonplace that all our students were using patient narratives in their learning. I do it for a small number of students. I do a little project which is about online patient narratives. So I have a group of 8 students every year who look at blogs and what they can learn and learn how to do a bit of narrative research. But the more the more frequently I run this, the more I think, well, all of our students should be able to do a project like this, not 8 out of the 450 students that we've got. So yes, I'm definitely a convert. I'm just trying to see how I can, get other people on board and using narratives in a similar way. And I think narrative research maybe doesn't always feel the process as accessible to everybody. But there's different ways we can use narratives, certainly. Thank you.
Does anyone want to add to that?
I was just thinking, certainly when I've taught reflection and reflection models in medical education, whether it is physician associates or medical students, it's always been quite dry, and the structure, I think, often on e-portfolios or other required sort of elements of reflection in medical education can be quite limiting in this kind of a way. And I don't think maybe some of these elements around the narratives are properly explored. They tend to be quite quantitative measures around reflection. I mean, so some can be written and some can be very insightful, but sometimes I worry it is a tick box exercise that people just want to get done or signed off, rather than it being a more meaningful sort of opportunity to explore things that have happened. So it's, I suppose, as medical educators, the prompts that we provide around reflection, and whether it is we pick up elements of Schwartz rounds or other narratives and things to try and get students to explore those kind of experiences in a bit more detail. I think, again, that is something that would be good to do. And the work that you mentioned there, Rini, sounded very much like in line with that kind of opportunity, I think.
Can I just chip in there? Yeah. So leading on from that, thank you, Rini. That was really great. And I think it's I just put it in the reference box. I see one of our colleagues was asking. I think the Point of Care Foundation, I think, are the main trainers, I understand. So we'll get some result. We'll put something in the chat box after. But if you Google the Point of Care Foundation, I think they're the main trainers, I understand, but really will be more of an expert. But yes, no. So linking to how to get, if we're talking about staff and students to reflect, sort of the thing that I've developed is from my interest of writing and being a poet anyway, and also a doctor, is using creative writing for reflection and personal and professional development. And yeah, that whole phrase beyond the portfolio, because people I've worked with and trained to FY1s, etc., I know they find the portfolio a little bit limited. And narrative style isn't always everyone's case, but the way I use creative writing, and I've run a module, and again it's an optional module, so it's a special study component. So I first ran it at Trinity College Dublin with Year 1 students who hadn't had so much, hadn't had any real clinical contact at Year 1, so 18 to 20-year-olds, but looking at topics such as what was their first contact with doctors, and sort of getting them to have a safe space, so once a week for 8 weeks, for 2.5 hours, to share their experiences in writing. So they didn't even need to share them, and that's an important thing. But actually, the process of writing, which there's a field that's related to it, so it's creative writing, expressive writing, reflective writing all overlap. So using reflective writing pedagogy, but also expressive writing, journal writing, poetry therapy, bibliotherapy, they're all related, or that's how I would approach it. But using that interplay as a means, as a space, almost like the shorts round. So having a space where you can go, and it can be on your own, because writing's cheap, and you can have a notebook, so you don't need to go and write with a group. But actually being part of a group develops people. What I found was it develops people's communication, so their written communication, their ability to share. We're taught how to give feedback, sort of watching someone at the bedside and give clinical skills, but I sort of focused on giving feedback to people's written work as well, which is a whole different kettle of fish. So using Selina's area, really, she studied English and literature, but creative writing workshop as a format of a small group learning. And I found that was very effective, and the feedback I got was very effective. And I've run it with Year 3 at Brighton Medical School as well. So happy to run it anywhere. I'm available. But it's something I love doing and would like to develop more, and with postgraduates. So the only time I've done it with postgraduates was at the AOME conference in Cardiff, which was great. So there was a mix of consultants, medical students, and some medical students, and qualified doctors and other professional staff, so not just medics. So I think that's, obviously I'm biased, but I think that is quite a powerful way. And I've done a systematic review which hasn't been published, but shows that creative writing can be used to maintain empathy and compassion, which is really important in our age of burnout, which is not an ongoing age, unfortunately. Connecting people, teamwork, working as part of a group or a small group, and being able to express yourself. So if anyone's interested, you can contact me. I will be running workshops soon. Thank you. It wasn't a plug, honestly. Thanks.
Fantastic. So all of this talk about empathy and reflection, the core of it is, at the end of the day, helping us to develop a better interaction with patients. So I believe, Richard, you have a method of using narratives to develop student-patient interaction. Oh, you're on mute.
Sorry, hang on. Right. And my interest here developed from looking to fill the gaps in students' knowledge, which was inevitable as a result of specialisation. But my main interest now is teaching second years and helping them to formulate a patient narrative by their interaction with patients. I think is a very important part of their second year learning. We were able to do this during lockdown by simulation, where I use a series of 3 different scenarios in a 1-hour session with groups of students to encourage them to take the history, to experience the particular sets of symptom patterns which indicate certain types of disease. It's really helping them to develop a narrative to assess the patient rather than working from a completed narrative presented from the outside. It was certainly extremely popular with the students. I've subsequently done a trial run with a live patient in a similar context, which again gives you as the teacher a very interesting insight into the way that the students interact with the patient. And it highlighted to me a concern that I've had for a number of years, that I'm not sure that as educators we support students whose first language is not English quite as much as we should, because in listening to the history-taking process, it's often quite obvious that is the case. And I think that it's an area which is almost forgotten about in terms of helping to develop our students' capabilities.
That's fascinating. Oh, Jane, did you want to
Yeah, I
comment
was
on
just going to say, yeah, because certainly, and Richard, I know that it's gotten to a point with some students where they've got to OSCEs in, 3rd or 4th year, and suddenly it is some, some kind of use of language or, something that comes up that then they are pulled up on. But obviously, it has been part of their history taking that hasn't been, sort of either addressed or supported previously. And I think that is a really important challenge to recognise, definitely, because we don't want to set students up to fail by not supporting them in this way.
And can I ask, Richard, as well, did you notice a difference in the way you were observing the students interacting with a real patient, as it were, compared to yourself? And did that, as an educator, give you any interesting insights on what issues you might want to address with them moving forward?
I think the particular, it's very interesting. You're observing the empathy that the individuals develop with the patient in a Zoom type situation. And in particular, it's interesting looking at how they resolve difficulties. Now, the particular patient had a genetically transmitted disease, and watching the process of inquiry into family history in that circumstance was extremely useful in terms of determining how looking at the interaction between the patient and the student, and also how they coped with the sensitivities around finding out whether the patient's children may or may not be involved and what the reactions to that might be.
That's really interesting. And I think you've touched, Selina and Richard, you've touched on a really important point about the authenticity in patient narratives. So how do we make sure that patient narratives are authentic, that the dialogue is authentic, and that isn't lost when we are transcribing narratives, and even when we're selecting which narratives to use in our teaching?
I think that's a really difficult question to answer categorically, because it's dependent on you as the teacher using a derived narrative from a real patient situation. And inevitably, you will be manipulating that to highlight the points that you wish to get over to your audience. So I think that there's inevitably going to be some degree of editing. But it also, the use of historical narratives enables you to apply the picture of the patient as a whole to what happens subsequently in their journey. So often when students are on a ward and you get them to do their presentation of a patient in a situation, then the subsequent pathway for that patient is obscured to them because of time. With historical narratives, you can then put in, well, this was the investigative pathway, these were the care objectives that were set, this is what had to be put in place to support the patient after their surgical intervention, and build up a picture as a whole, rather than just a brief snapshot in a half-hour ward-based experience.
Selina, do you want to add to that?
Yeah, just I think that's really interesting. I know you were saying you focus on second year students and teaching them to take histories. Just reflecting on sort of my own experience, because we're seeing medical students coming back to the wards now, is also about how they're taught to gather that first person narrative, to take that history. And just wanted to ask your opinion, and maybe other people's opinion in the chat, is about the format in which we teach students to take a history and to get that narrative. So I was taught this way initially, and I saw the students sort of presented the history in this way, as you're starting off in the typical presenting complaint, history of presenting complaint, and so on. And usually at the bottom, we've got ICE, ideas, concerns, and expectations. And I don't know if it's taught that way knowingly, but then that often is the last thing that a student will come to if they've got time. And I've sort of finding now, as I'm a foundation doctor and also working in primary care, that I often start with the ideas, concerns, and expectations. But I've only got to that stage later on in my training. So I guess I'm wondering, is there any scope to redress the way that we're initially teaching students to interact with patients and gather those histories?
Certainly, if in Liverpool, the students are taught, first of all, in a sort of classroom setting, they're given a method which you've described. And in many ways, my job as a clinician is to help develop that. And importantly, point out that the first thing is let the patient talk. There are some patients who will do all the work for you simply by, all you have to do is listen. But then there are the other group of patients, often the less educated, the ones who are perhaps intimidated by the hospital environment, who are much more reluctant to talk through their experience and to talk through what they've come across in the course of their illness. And you need a structure to help draw that out. And so I think that encouraging students encouraging the patient to talk first and then perhaps applying structure is useful. But of course, the structure comes into its own when you're communicating that information to other healthcare personnel, so that with having a recognized structure, it's much easier to assimilate the details of a particular patient.
I think, if you don't mind me coming in, I think that's a really good point that both of you have raised, Richard and Selina. And my experience as a clinician, I mean, working with people that can't communicate, so people with stroke or traumatic brain injury, how do you elicit the narrative then using that structure? And I was trained 25 years ago, and ICE didn't exist then. So, Prof McManus, we were talking about him before, taught me communication skills. But, so yes, we have the same. History taking doesn't really change the structure, but, new things have come in, new, obviously, tools for communication skills training. But yeah, thinking about that, how the narrative, I think coming back to what I was saying before, narratives aren't linear. We are, where's our place? Lots of questions have come up since, Selina's project and coming today, but, where's our role in the narrative? Because we're entering the patient's world. They're in our world in a hospital, in a GP surgery, but, some of us who've worked in the community, we then enter their world. One, can they communicate? Who else do you need to involve? That's when the interdisciplinary care, speech and language therapists, I'm using a specific example, but you will need to involve other people, the family again. Where do we fit in the narrative? Because if you think about it, I think all of us must have been patients at some point, even as kids, if you have a jab or whatever, a vaccine. But if you think about, and that's what I get the medical students to think about, if you think about yourself on a receiving end of care, other people are stepping into your lives. And I think that's really important to understand. So yes, there's a straight structure and how we present it, but I think, enriching that narrative by talking exactly what Richard says, letting the patient talk and tell you. Obviously, we need to start somewhere, but the skills of open questions. I've done a bit of training in oral story taking, and that's for community work, and that's really different. Now, I'm a chatterer, as you can tell, but it is sitting and listening. So it was like, oh, this is interesting being a doctor and having that structure, but then just being quiet and just using trigger questions. It was about the war. So people in my area who had been involved in the war. And that, I think maybe we could bring some of that in sometimes to, there's benefit there of exactly what Richard says, actually not doing too much talking and creating too much structure, because that person has an aspect of that snapshot of their story to tell for why they came in today or what's happening today. And I think we're at risk of interrupting it sometimes as clinicians. I'll just say that. I'm guilty of it. But I think I've learned, because I've worked with people that can't speak and, can't communicate so much, that, I think that's really valuable. It's a really interesting discussion.
Okay, it is interesting, especially with Richard, when you pulled up about second years, because I think obviously it's still quite early in the programme then, and students are very keen to not miss anything, so they are following the list or the structure that, the ICE that Selina mentioned. You're going through this process, aren't you? And sometimes there's a pressure just to get that information down rather than build up that discussion or, create that relationship so the patient can actually, explore or explain a bit more in their own words about their experience. So it's taking not the pressure off the student, but giving them the confidence to allow that discussion to occur as well. So some of it is because students, and I appreciate how nerve-wracking it is, especially first, second year, but giving them the confidence to let the patient talk as well, I think is key.
Oh, that's fantastic. I'm aware of time. We've got 8 minutes left. So there was a question in the chat. Can you comment on the value of quality formative feedback to students' reflective writings?
Variable, if I'm honest. But Selina will probably have more insight into this, certainly from recently, because I think we have to be realistic about the pressure on ward staff and in clinical environments as well. So, whether the feedback is written, how it's delivered, who it comes from, how students might place certain value depending on who the patient or the feedback is from, whether it is from a consultant or a registrar or a staff nurse. That might vary on the value they place upon that feedback as well. So I think there's a massive amount of things to consider there. But Selina, I don't know certainly what you think.
Yeah, I think firstly, getting feedback can be a challenge in the first instance, and I think as well it depends on whether you're in primary or secondary care. That can be quite different. And also so the question was formative feedback to students' reflective writings. So I don't really have much experience of that, only in terms of the foundation portfolio. So we have written a few reflections and I've had the opportunity to discuss them with either clinical supervisor or, in my case, my educational supervisor. And I think that can be a really good way of processing sometimes challenging or emotive experiences. But again, I would question how well supportive medical students and perhaps foundation doctors are to actually engage with that and use that to its full potential. Because I studied English before and because I enjoy writing, I know how to use writing as a sense of catharsis. If I've had a difficult experience, I can come home and I can write a reflection should I want to, and that would be a useful experience for me. But are other students being taught the value of that and how to use that? And if they're not, given that a lot of medical school and certainly foundation training is evaluated through the use of reflection, should they be better supported in using that? And equally receiving feedback on that? I think that's an interesting question.
I think that's true. But in a work environment, you also need to be very aware of mechanisms for giving oral feedback. I used to work in acute situation. There would often be life-changing events taking place. And that clearly had an effect on individual members of the team, particularly if they felt that they had in some ways contributed to the patient's demise. And verbal feedback in reflection under those circumstances, I thought I was reasonably good at. But I do think that the idea of written reflection afterwards as a way of reinforcing that may be a good way forward for the future.
I was actually going to reference Prof. Ward's work, which is internationally renowned. So I think, Ryan, you asked if Hedy would be able to summarise, because you'd be able to summarise, but I know that Hedy, you've created rubrics with your team for assessing reflective writing, and I know working in different medical schools, I've marked some reflective essays and there are different rubrics and different frameworks that have been used, so I don't know if... Yes, hello. Hello again. Thanks, Ryan.
Hedy, you're on mute.
Can you hear me?
Yes.
Thank you so much. I'm so honored. Your work is wonderful, all of you. I've just loved hearing all of your ideas. You're so dedicated. It's fabulous. I just think you guys are amazing. I just want to say, Roger Kneebone called it reciprocal illumination. And I love that term because together in a relationship through the guided reflective writing and providing formative feedback, we see when faculties are trained, they gain so much because it doesn't take as much time. So they can even write a cogent paragraph that students feel seen, feel heard. They actually thank the faculty for that because they feel like they're not writing to the wind. So it's a really nice paradigm. I would just say be scholarly in your approach, okay? Whatever you do, think about it within the theoretical work of why we do reflective writing, how we guide it. Take a look at some of the papers that are published on that, and then see, how your work might align or even then fill gaps that we haven't filled. So I just want to encourage you that way, but also take a look at some of the work on formative feedback because I've been struck by some positive benefits for both students and faculty. And thank you so much for inviting me to even say something.
Oh, thank you.
Great.
So we could talk for hours upon hours on this subject. That's why we have the second session in the first place. We've got 2 minutes left. So Jayne, Selina and Roshni, would you be able to give a quick 30-second summary of one idea that you think could best integrate patient narratives into our education, into our curricula, institutes, anything that you think would be useful or a recommendation?
I'll go first. That's evil. 30 seconds with me. But I've written a few ideas, but I'm sorry. Thanks, Hedy. But I'm thinking again back to, getting as much, I know it's difficult when you don't have patient contact, but perhaps introducing, patient visits. We were talking about this, Jayne and I, before, into clinical skills and communication sessions. At the moment, we have simulated patients who are actors normally. Sometimes you have expert patients, not sure about that term. But I think getting patient contact, even if you're not in the wards or going to a GP surgery from year one would be really valuable, because otherwise you are getting the perspective. I mean, we fictionalize, think a point I didn't make, we fictionalize. I've written cases, I've written OSCEs, I've written workshops. We actually fictionalize patient narratives, don't we? I mean, I've just written one about a young chap with brain injury who's a musician. I had great fun writing that, but he's a composite of lots of patients I've looked after. Wouldn't it be great to have people with lived experience coming in earlier in training? So coming into the classroom setting, so university setting, if we can't do it in a clinical setting, and that could be done online. I think that's my 30 seconds. Thank you.
Fantastic.
That was Roshni. I mean, exactly my thinking as well, as working together to develop resources, written resources with different people's skills, whether it is storytelling, patient experiences directly, our clinical partners and other healthcare professionals, really. So it's coming together to create scenarios that are valid, that are real time, that reflect real experience, and also that journey that Richard mentioned as well. So, you can follow through what happened to that patient, their family's reaction, how people engage at different points and you know, certainly positives and things that could be done better from a reflective point of view as well. So that's very much what I would like to do going forward. Thank you.
Yeah, and I suppose just going to echo the sentiment of that any opportunity to engage patients who are willing to share their first-hand narratives is going to have multiple benefits for students, all types of healthcare students. So I've been aware sort of during lockdown that patients have been sharing their stories over Zoom in the format of AMA, so Ask Me Anything sessions. And I really like this because it sort of breaks down the hierarchy between the patient and doctor. There is sort of no hold. You're allowed to ask any sort of questions about their particular condition, how it affects any aspect of their life, and you can be part of a forum with other type of healthcare students, and I think that's really useful. But then you would definitely have to follow up those type of sessions with specific support for healthcare students to process those topics, those emotive situations that they're experiencing, whether that is through processing it through reflective writing or poetry. There needs to be, I feel, integrated more formally into medical school curricula, some type of support for dealing with those interactions with patients.
That's fantastic. And on that note, thank you to everyone who has contributed today in the chat and live on video. And thank you to our 3 panelists today. So a video of the session will be made available on the website in the next few days. That will contain everything, as well as some of the resources in the discussion today. And yeah, no, thank you. It's been a really interesting session, and I've got 2 pages of questions that we could have explored. It's such a fascinating topic. So if you're interested in more ASME Bite-Size, then next week there is a session, Wednesday the 16th of September at 4 p.m. You can join the MedEd Travelling Fellowship 2019 award winner, Dr Anik Atherley, as she delivers a session based on her award-winning work, Diverse, Dynamic and Deliberate Networks of Students Transitioning to Clinical Training. And you can see all of those events and more on the ASME website, www.asme.org.uk/events. So again, thank you to everyone, thank you to our panelists, and have a great afternoon.
Thank you.